Respected Chairperson, Panelist, my dear fellow colleagues, students, a very good afternoon. I am Dr. Bijoy Dutta, esteemed professor of cardiology. Today is my topics on mandatory versus complexities. I am acting as an esteemed professor of cardiology from the long time in NICVD. I want to share one or two cases with all of you. Mr. X, 61 years, diabetic, smoker, with effort angina, CCS class 4, on guideline-directed medical therapy on maximum medical management. His ECG shows ST depression in B1 to B6, and echo shows anterior hypokinesia to ejection fraction 46%. As the maximum management falls, we plan for his coronary angiogram. It shows that 90% stenosis in medial AD, around the origin of the D1, and this is Medina 110 class bifurcating lesion. So we plan for his right system is normal, so we plan for PCI, and pre-dilatation is done with 20 to 13 millimeter of semi-compliant balloon at 12 atmospheric pressure, keeping a wire in the D1, and a long stent 2.75 into 48 millimeter giant expedition was deployed. And after stent deployment, we see that there is stent under expansion. And we try to dilate it with NC balloon, 3 into 15 NC balloon. Then still you see that there is under expansion. So we dilated with 3.5 into 16 millimeter balloon at 14 atmospheric pressure. And while we are serially presenting, but patient dilating, and that patient develops suddenly shortness of breath and chest pain. And look, there is grade 3 perforation. And we tried to prolong balloon inflation for 10 minutes. But it failed to seal. And again, prolonged balloon inflation for 20 minutes. Fails. And then we tried with the same balloon for the 30 minutes. And it also fails. Still there is leaking. And finally, we could manage a covered stent, that is Graftmaster 3.5 into 22 millimeter. We deployed it at 12 atmospheric pressure, and after deployment, this is the final view. And we finally seal the perforation. In my second case, it was a 52 years male smoker, diabetic, hypertensive, dyslipidemic patient, chronic stable angina, CCS class 3, and his ECG shows T inversion is 2, 3, and ABF, and ETT is positive in stage 1. His ejection fraction is 55%, and echo shows inferior wall hypokinesia. Angiogram shows 80 to 90% stenosis proximal to mid RCA, pre-dilatation downwards 2.5 into 12 millimeter maverick balloon at 10 atmospheric pressure. Then we deployed resolute onyx stent, but after deployment, it shows that there is still some under expansion of the stent. So we tried to post dilate the lesion with NC balloon 4 into 15 millimeter at 12 atmospheric pressure. When we are post dilating the lesion, then again severe chest pain develop, and it shows like that. That is grade 3, or in some cases grade 4 perforation. Then we are in a hurry. We tried for prolonged balloon inflation, but nothing was in my favor. everything goes in vain. As the patient is going down and it is in going shock and respiratory rate is more, pulse and BP was going unrecordable. So we called for the covered stent, but at that time we could not manage the covered stent. So in our hand, we have a plan that we will try to deploy a long stent. That is, the previous stent was 3.5 into 30, and so we deployed another stent that was 4 into 40 millimeter size, and we tried to deploy it, and we tried with this stent balloon, with prolonged stent balloon inflation at low atmospheric pressure, at 8 atmospheric pressure. And finally, we see that the leaking are gradually down, reducing, and still some leaking. So we again tried with a prolonged balloon inflation, that is 4 into 15 millimeter, that was in our hand previously. And finally, this is sealed off. So, incidence of coronary perfusion is, though rare, it is only 0.2 to 0.6% of all PCI, but it may happen anytime, even in expert hands. So, the balloon, overcharging of the balloon or stent, guide wire damage, CTO PCI, there is highest risk in CTO PCI, there is 4.8 to 8.8% risk, and use of atherectomy or laser ablation. The incidence may increase in the future as the increasing complexity of attempted coronary lesions, complex coronary lesions such as CTO. Clinical sequelae following coronary artery perforation there may be death, myocardial infarction, or cardiac tamponade. So immediate and sustained sealing of the perforation to prevent hemodynamic collapse with covered stents represent the most common method to treat the site of hemorrhage when initial conservative management like prolonged balloon inflation fails. According to the Ellis classification, there is type 1, type 2, type 3. In my case, the first case was type 2, and in second case, this was type 3 for perforation. And successfully, we managed both the patients. And this is the algorithm for management of coronary perforation, class 1, class 2, class 3 perforation, and we managed it accordingly. So the take-home message is, post-dilatation is mandatory in most of the PCIs. It may cause coronary perforation even in expert hand. So for the young colleagues, don't be panicked if there is any perforation. Keep your brain cool and try to handle with patience. Assess the situation first. Don't inject repeatedly. Never lose your wire and guiding catheter. Make a sequence of your action plan. Ensure all the hardwares with covered stent if possible. Call for cardiac OT. In this case, we already called for cardiac OTs, but ultimately it was not needed finally. So low pressure, balloon inflation, pericardiocentesis, covered stent, and coil embolization may be life-saving. Thank you for patient hearing.